Thank you.
I don't think my reference.
They went that way.
Okay, perfect.
We okay? Okay, I just got the ruling that we are on. So GK, if we could get started.
Okay, great. Thank you, Mr. Chairman. What you're going to see today is another presentation, and this presentation is going to be by HMA. But before we do that, if I could maybe just do a few housekeeping issues. One of the things that we need to make sure that we do is that whenever you speak, if you'll just simply grab the mic and turn it toward you. We try to structure this where no more than 2 people have to share a mic. The reason for that is because we're capturing this on video, and so we ask that you make sure that the mic is available and that you speak loudly. We're also going to talk today, after some of the presentations, about future meetings and the timing of those future meetings. I believe we've sent some material out to you, but we'll talk about that also. And Mr. Chairman and Madam Chairman, we, as we go through the meeting, we'll have comments as it relates to that also. So I'm assuming everyone has an agenda now, and if the chair have any comments to make at this time, if not, we'll move.
GK, could I just interrupt real
Yes.
quickly? I think I know of at least one person at the table that wasn't here last time.
Okay.
I wonder if Sarah could introduce herself and why you're on this committee with us.
I'm Sarah Hollenstein. I live in Northwest Tarrant County, and I'm here because J.D. Johnson asked me to be here.
Okay, that's a good reason. Okay, did we miss anybody? Okay, good.
Are we ready? Okay, great. So we'll now move to item number 2, which is our presentation by HMA. Lori Weiselberg is a partner and a principal with HMA, and she is going to take you through a slide deck. That slide deck is about 45 minutes in length.
Okay, so unfortunately, I can't put this up here, so I'm going to be sort of looking down, so I apologize in advance. So again, I'm Lori Weiselberg from Health Management Association. I've been very pleased to be part of this process over the last 5 or 6 months. I think the first day that I was on the job, I met with you.
Me? Is that memorial?
And since then, we've met with a lot of other people. And we're really grateful.
There's you, then there's
Okay.
a lot of other people.
Okay, so the name of this project is Tarrant County Long Range Planning and Analysis for the Jps Health Network. We covered a number of different areas in the last 6 months. We have a piece on Voices of the Community, our stakeholder engagement process. I'm going to be talking about that today, as well as the Community Health Needs Assessment that we did, and some exploration of opportunities for JPS and Tarrant County Public Health to collaborate with one another. There are several future draft report reviews or chapters to review with the Blue Ribbon Committee in the coming months. So today we're just going to do those first 3 and several others in the future. So this is actually taken right out of the request for proposals that we responded to. So this is our project overview. So Tarrant County, with the assistance of Jps Health Network, is looking into the future to anticipate changes in population demographics, technology, and how we provide healthcare services. And with that information, the County Commissioner's Court will be able to make informed decisions to improve the health status of the county. We have been fully engaged in the project over the last several months. We have monthly in-person updates with the court, and JPS Board of Managers Planning Committee meeting we had in November. We have weekly conference calls with the county and JPS collectively. We have a bi-weekly dashboard and written report updating on our progress. And right now our project is on time with no completion of risks identified. These are several pieces that were taken right out of the RFP to kind of explain The focus really talks about a market analysis, exploration of what JPS's current role is, talking about the requirement to really engage stakeholders and talk to people in the community, and then to do an evaluation of all of that, actually, as it relates to JPS's current and future plans, and to reconcile those and to say, okay, given what JPS's plans are, this is what we recommend. Here might be some additional opportunities, et cetera, or different prioritization. And then a full report will be submitted. So we have a draft report right now, and again, what we're doing is just taking selected chapters from those, from that larger report and presenting them sort of in more digestible pieces to the Blue Ribbon Committee. So, so here are all of the chapters. So again, voices of the community, macro trends in the United States, healthcare delivery system. So what's trending? Community health needs assessment, as I mentioned, system capacity and population needs. So as the population changes, grows, what are the capacity issues, or what implications does that have? The JPS delivery system, really describing that quite well and operationally. And then talking about, again, public health and JPS's relationship, and then talking about money. So the chapters that we will review in the future, hopefully in the next couple of months, will be system capacity and population needs, the JPS delivery system, so also talking about primary care, so those community clinics, as well as specialty care and behavioral health, as well as financial perspectives. So just starting out here with community engagement, and GK, we hadn't talked about whether I should take questions as we go. What do you think?
I think that if any of the committee members have questions as we go ahead and ask them, and because even as we get to the end, if there's more questions, we'll handle that also. So
Okay.
if you feel like you would like to have a question directed to either Lori or someone else, just.
Can she have a microphone?
Can you not hear me? I do have a microphone on, but it may be a little too low to pick up my voice. How's that? Is that better?
Better.
Better? Okay, great. Terrific, thank you. Okay, so community engagement. One of the earliest and most important activities was to really listen to Tarrant County community voices regarding health needs of the county and how JPS Health Network should meet those needs in the future. The engagement work had three different components. One was focus groups. The second was community forums that many of you have probably come to. And the last were individual interviews. So I want to go through these a little bit more in depth. So the purpose of the focus groups were to really identify community experience and perception of JPS, experience with JPS, and looking at community health needs and opportunities for JPS and others to meet those needs now and in the future. So not just JPS. What this project really is about is to take a look at the entire county, the needs of the county, and the role that JPS plays within a much larger delivery system to meet the needs of folks in the county. So we had two focus groups. They were held in November, and they included users of JPS, so patients, as well as community health activists and advocates. We had a total of 20 folks. We had word-for-word transcripts prepared and a summary analysis. And these are the themes that emerged. The first one is that JPS improvements have been recognized and appreciated by the community. And everyone said, oh, it was probably about 6 or 7 years ago. So there was a leadership change, and people recognized that and felt the difference in their improvements in the quality of care. The next is interest in having JPS focus more on prevention and social determinants of health. Social determinants meaning those things that are not necessarily health care that affect a person's health and their health outcomes, with particular emphasis on food security, food policy, availability of healthy food. Food kept coming up. Do we have any? We only have cookies. But anyway, so that was one of the things. And we know that with the population growing, capacity is going to be an issue, and I think people in the community recognize that. And if we can keep people well, it won't stress our delivery system as much.
Laura,
Yes.
could you give the committee a crash social determinants of health?
Very crashed because we have a limited amount of time. So I would say education, employment, access to safe housing, safe places to exercise and live, clean air, clean water, clean soil, those kinds of things that really affect people's health in a significant way, but isn't health care.
And where did these come from?
Where did what come from? The
The
recommendation?
social determinants of health. It's a paradigm that was developed by, I believe, the MacArthur Foundation.
I'm not sure who coined the term social determinants, but public health has been involved and charged with addressing those things forever. So, yeah, it's but now I think it's more accepted, and in terms of people who provide health care, partnering with others who do that work more directly in promoting improved quality of life, we can say. Service expansion and creativity in service delivery is required to meet current and future needs. And this came up. We had a really diverse set of people in the focus groups. And, as we talk about creativity in service delivery, you have a lot of linguistically isolated communities and folks with different cultural backgrounds. And it requires creativity to engage those folks in a healthcare delivery system. The next was that JPS services should be more systematically promoted in the community, that sometimes people didn't realize that there was a JPS clinic in their community. There's room to improve patient experience. There were just examples given about the call center and wait times and not getting a call back, and that's something to work on, so opportunities there. The next is community partnerships are required to overcome challenges in meeting needs of diverse populations. There were several community-based organization representatives that were ready and willing to work in collaboration with JPS or build on existing collaborations. Behavioral health service and support needs were definitely a priority. More attention should be paid to caregiver support, particularly as the population ages, and we'll talk about that when I talk about the demographic trends, but that's very critical. And then there was concern about over-medication of senior citizens and also the cost of medications and the need to be cognizant of the cost of medications. So those were the focus groups. These are the community forums. So again, the purpose was similar here, to introduce the planning process, to obtain input from the community on health needs, on the role of JPS now and in the future, and also to inform the public of additional opportunities for monitoring and tracking how this process is going. So we had one forum in each precinct. They were posted by the Commissioners Court. We had a total of 158 community members participate. They were about 90 minutes long, and we analyzed the themes. And there were 4 themes that came through very clearly. And we noted how many times these issues were brought up, and so these are the 4 that came to the fore. The first one was the strong perceived need to expand inpatient and outpatient behavioral health capacity, both now and in the future. Several stressed early intervention, calling out the limited child-adolescent services for behavioral health needs right now, and concern over the growing need. The second was concern regarding the lack of transportation options and the difficulty this poses for accessing JPS downtown location. The next was perceived need for additional clinics. That kind of builds on that second piece. It's hard to get downtown for some folks. So improving access in the local communities. And the last one was perspectives from some speakers were that JPS should focus on the needy population, those who are unable to afford care elsewhere.
Now, I'd like to make a comment on the first item, dealing with the child, adolescent, and the young adult services for behavioral health. It's my understanding that Cook's has just opened up, I believe, 15 new beds, psych beds. that are inpatient beds, which is going to be a huge relief for the community. So we're starting to see some movement there already.
Okay, the next were stakeholder interviews, and it was the Commissioner's Court, the County Administrator, Administrative Leadership, and JPS leadership that identified individuals and organizations from which representatives should be drawn to interview. We interviewed 107 individuals, and these ranged from CEOs of hospitals to the folks who manage the Child and Family Services at the Salvation Army. So it was really quite a wide range of folks. And we have confidential interviews, and those findings really guided the report. So we had a lot of data analysis, but those voices from the community really gave texture to what we found. Okay. So this is a kind of abrupt change here. So we're starting the Community Health Needs Assessment, and this is a summary of health status in Tarrant County. So through publicly available data sources, we identified, we had in our report, you might see that we have many charts that identify where Tarrant County population is compared to the Texas, the state as a whole, and then compared to the United States, and we looked at benchmarks. So these are the ones that really came to the fore that were most problematic in Tarrant County. So based on self-report, so these are our national surveys, but they break them down by zip code. Based on self-report, access to affordable primary care and dental care for low-income persons appears to be difficult. Infant mortality in particular zip codes and is of concern. So you can look at some of our charts and it'll say infant mortality average is about average for the state or the country, and it kind of washes out. But Tarrant County, like many counties, is a tale of two cities, right? Or two counties. One where infant mortality, for example, might be very low in some populations and very high in others, which is why we did a lot of mapping. So we'll show you some maps later. So again, infant mortality, in particular zip codes, was very problematic, and late entry into prenatal care was a significant concern. Also, the high rate of sexually transmitted infections was quite high. Behavioral health, so major depressive episodes, and these are self-reports, are almost twice as high as the national average using those same self-reported surveys. And while substance use for this region is lower than the national average, it has a significant impact on this community. Adult obesity, diabetes, high blood pressure, and cancer are some key health concerns for the county. Childhood immunization rates and childhood obesity are also high. Our immunization rate is low, obesity is high, so they are in need of attention. And again, linguistic isolation. This is people age 5 and above who speak a non-English language at home, and transportation barriers make it more challenging to navigate and to access the healthcare system. So here's an example of one of the many maps that we put in the report. This is an infant mortality heat map. And a heat map just identifies areas where there's higher prevalence as compared with lower prevalence. So we have that broken down into quartiles, so 4 different shades that indicate a higher versus a lower prevalence of a particular condition. So this is for infant mortality, and you can see the darker shaded area in the southeastern part of the city and into Arlington, that those are higher infant mortality rate areas. This is another one based on adult diabetes. So that's, again, the prevalence broken down into 4 quartiles with the higher prevalence around really pretty much around the perimeter of the county. Some more internal. Now I'll talk a little bit about, let's see if there are any questions about any of the health status issues that we just talked about.
That last graph there, just based on your experience, is that an unusual looking graph the fact that all the way around the edges you have the higher prevalence? I mean, I don't have anything to base it on, but it just seems kind of strange to me that it would.
Yeah, you know, it doesn't, there's not a huge difference between the lower prevalence and the higher prevalence. So I don't think it's, I'm not surprised by it, you know, I probably wouldn't have been surprised by a lot of the difference. Oftentimes in these kinds of heat maps you see, you know, if you look at some of our poverty maps, you see, you know, concentrations in certain neighborhoods that you know, and but these are more, they're more sensitive, you know.
Yeah.
So.
Do you have any correlated map related to income and age and so forth?
We do
With
have
these,
income, we do
issues?
have age.
If you put the two overlay to see if there's any pattern there?
Yeah. We have them that we can put side by side. We didn't do the overlay. Okay, the next is population projections. So this is a really key piece because as we do long-range planning, we need to know what's happening to the population. So we know that over the next several decades, the Texas population will be characterized by growth, really quite enormous growth compared to the country as a whole, increasing diversity and aging. So in Tarrant County, we expect a 46% increase in the population in the next 20 years. That is huge. It's really huge. The total population will grow from about 2 million in 2017 right now to almost 3 million in 2037. Assuming population proportions at federal poverty levels remains about the same, in 20 years, there'll be over 1.2 million residents, or will be less than 250% of the federal poverty level. So that's a very high number of people of very low income. And over 1.8 million residents will be less than 400% of FPL. And I broke it down into 250% because that's where some of JPS's subsidy programs come in, families at that level or below. And 400 is where the Obamacare exchange kicks in, but that remains to be seen. Right? Okay, so JPS connection eligibility for those who are less than 250% of the federal poverty level. Just want to give a little bit of background on that. So that program provides, it's called JPS Connection, and it provides affordable access to doctor appointments, specialty care, and prescriptions for those who qualify and apply. And the eligible population is people who are 18 years or older, non-Medicaid eligible, so this is really last resort, and less than 250% of the federal poverty level, and they need to be a Tarrant County resident, so they can't live in Dallas County, they can't be undocumented. And again, as a payer of last resort, the program includes a number of different types of subsidy for those who don't have insurance, for those who are homeless, for those who are on Medicare but can't afford the copays, and those who may have other insurance and can't afford copays or deductibles. So we expect that JPS connection eligible population, which is well, it's currently 425,000, or approximately 49% of the total population that's less than 250% of FPL. But if you look at just the adults, and just the adults are eligible, it's higher than that. So they're covering quite, a majority of people in that income bracket. We expect the JPS connection eligible population to grow from approximately 425,000, which it is today, to about 621,000 in 2037. That's an important number to keep in mind. So we talked about the growth of the population. This talks a little bit about the diversity of the population. So a key indicator of percent change in race and ethnicity in the coming decades is the percent change based on the last two census surveys. So we look at the past and projects us to the future. So when we compare the census for 2000 to the census for 2010, we see that the highest percent change is for Hispanics. So it's a 69% increase. And they added 197,000 people between 2000 and 2010, which is huge. Actually, Asian is the next highest percent change. They were at about 60 or 61%, but their overall numbers are much lower. So Black is at 45% increase, white at only 4.7% increase. So again, Asians and others have high percent change with growing populations as well. So again, increasing diversity. Between 2015 and 2021, we expect the population percent change in early childhood to be about 10.5%. Overall adult population about 13.5%. Those are high growth, but they are more typical than what we've experienced before, which is as compared with the senior population. So 65 years and over, we're expecting an increase to be over 40%. So that's just the next 6 years. That's huge. That's all of us. That's the baby boom population. That's moving into 65 plus. Here's percent change in the population age 65 plus, just to give you a sense of what's in the report, so you can see where the older people are compared to where those have not yet turned 65. So the take-home message here is that Tarrant County will likely require substantial additional healthcare delivery system capacity, given the population growth overall. The current safety net healthcare workforce shortage will need to be addressed to ensure adequate workforce for the population. The county will also need to use approaches that engage an increasingly diverse community and ensure right sizing of services to meet the long-term service and support needs of the rapidly growing aging population. Here is a map, and I brought several much larger versions of this that are easier to read. This is the primary care safety net, and it shows where Cook Children's primary care clinics are, the federally qualified health center locations are, where free and charitable clinics are located, where JPS medical homes are located, where JPS school-based health centers are located. So I think this will be really helpful as we continue in this planning process to take a look at where the population is, where the population is growing, what are the health issues, where are the sites that are supposed to be their medical homes or their base for a coordination of care, and where aren't there. We also put in some shading here where there are health profession shortage areas and medically underserved areas. And we put the bus system and commuter rail routes in there as well. So this is for behavioral health, and this plots JPS behavioral health sites as well as MHMR sites in the community. So
before you go on, I think one of the things that we heard in the community groups and what we see here is if the blue is the bus system, we can see a large portion of our county doesn't have access to public transportation. And if they don't have access to public transportation, how are they going to go to either a clinic or to a hospital? And our goal is to make sure that that trip is not in the back of an ambulance.
At the same time, we're not a transportation company. Communities need to make the decision that they're going to provide public transportation for their citizens. We can't get in the bus business or the light rail business. We could. Not with the current millage rate, no, we couldn't.
And Commissioner, that was not what I was suggesting. What I was suggesting is the fact that there is a substantial absence of public transportation out there.
I certainly agree that that's true.
Well, and we can't solve the transportation, but maybe we have to go out to those populations, possibly,
right.
via clinics and that sort of thing.
Mm-hmm. Technology.
Yeah, and technology, yes.
Okay.
What about mobile units?
something like that? Are you
I'm
speaking-
sorry?
Like mobile units, are you speaking of something
Well,
like that?
it could be all kinds of things. It could be a clinic, a mobile unit, it could be a freestanding emergency room, it could be just, there are just a multiple different options that we might want to take a look at. But the transportation issue is really critical, especially when you look at Arlington and Northeast Tarrant County, and I know that there is proposed rail out to Northeast Tarrant County, which I don't know when that's actually going to take effect, but the funding is already there. So I think that there are going to be certain sections of the community that maybe help is not that far away, but then you look at Northwest, I don't know of any rail proposals or bus proposals or anything going northwest, west. I mean, maybe the commissioners know that better than I do, but is there anything even in the forecast for those areas?
Not,
Yeah.
not in the capacity that you are talking about. I think when it comes to transportation, I agree with Commissioner Brooks. We have to leave that to the specialist of that world. But it doesn't mean that we shouldn't collaborate with, say, for example, the city of Arlington. The city of Arlington is actively pursuing, exploring solutions to public transportation right now as we are sitting here. So perhaps now is a good opportunity to collaborate and engage in that conversation with them and maybe steer them, that conversation toward healthcare as well, okay? That's where the opportunity come in. And I know that Arlington and several other smaller cities does not have the financial resource like the city of Fort Worth does. And the amount of money that we injected and have been injected into the traditional or the legacy transit system and covering only even less than 4% of the population, ultimately we're going to have to ask ourselves a question: is it working? And the amount of money that we are injected into that solution, is it worth it? And we also have to ask ourselves a question: given the current technologies that are available in the market right now, should we look at a different option? Should we think outside the box? Okay, so I mean, these are the things that we need to explore. So looking to the legacy solution alone, it may not be enough.
I'm glad to hear that the city of Arlington is finally looking at mass transit options. And certainly I would agree that we need to be at the table advocating for collaborations over healthcare when they do that. I guess I would disagree with you somewhat on your discussion of the legacy system. The legacy system is working for those who are contributing to the legacy system. There are communities all over the county, however, who are not contributing to the legacy system, yet are expecting services from it. That doesn't work.
Well, I mean, that's not the purpose of the discussion. Right. We're not here to having a discussion about the transportation model. So I yield to my colleague.
Okay, so we'll move on and just talk about the Community Health Needs Assessment key recommendations. So from this whole piece that I was just talking about. So again, growth, aging, and increased diversity of the population will have significant implications for the county and for the JPS workforce. We're recommending that the county and JPS determine, and we're working with them to do this, future population demand for safety net care using national benchmarks and a strategic utilization plan criteria to estimate expected countywide shortfall in provider and hospital services. Emphasize prevention and management of prevalent and controllable conditions like diabetes and hypertension. Those might be our top two. Efforts should include partnerships with public health and community-based organizations. The third is ensure sufficient capacity of services to meet the long-term service and support needs for the aging population. And the fourth is use approaches that engage increasingly diverse communities. One example is community health workers recruited from those communities. So these things are all easy to say, less easy to do. but are promising opportunities. The next is public health collaboration. All of you are probably familiar with Tarrant County Public Health. It's a very strong local public health department. So its mission is to safeguard the community's health. So they do air, water, soil testing, go out to restaurants, they do health promotion, and they do some limited clinical services. But they don't have primary care, they don't have behavioral health care or mental health care, as some public health departments do. And then Jps Health Network. So quality healthcare provider with mission to transform healthcare delivery for the communities we serve. So again, a different mission. They provide primary care, specialty care, hospital care, trauma services, emergency care, those kinds of things. So their missions are different. They're very complementary, and they have the same overall goal of a healthy Tarrant County population. There are lots of opportunities for the two to collaborate, and it's just been, these probably the last decade that public health departments and health systems have been collaborating more, and there are actually some legislation for them to do so. But current collaborations are focused on reporting notifiable diseases, so these are communicable diseases that the state needs to know about. Controlling communicable diseases such as tuberculosis. They also collaborate on classes to support chronic conditions such as diabetes management. There's bidirectional referral to some extent. So JPS might have strategies to help people quit smoking, like a nicotine patch or prescriptions, that kind of thing, and the public health department may have classes for quitting smoking. So again, they really complement one another. Some collaborative work on health policy issues that may address some of those social determinants of health that we talked about. So we were asked to come up with some recommendations for further collaboration and other opportunities that present themselves for health department and JPS. And the first one we thought was to really create a formal process for collaboration. They know one another, they meet together periodically, but it's more relationship-based, and someone has a patient, they call someone else, so I need to get them into that quit smoking program or that kind of thing. But there's not a high-level, regular meeting and involvement in one another's strategic planning processes or campaigns from the very beginning, or priorities as a partnership, and those are the kinds of things that could benefit actually both of them and the population. The second one is working together to sustain priority initiatives funded by this DSRIP that some of you are not familiar with. It's Delivery System Reform Incentive Payment Program. So it's a lot of money that came into the state, came to JPS as a regional coordinator, and to JPS as an entity, and also to the Public Health Department, to work on promoting health and prevention of diseases and containing costs. So those things need to be prioritized and sustained. So that collaboration is very important, and I know that they're working together on that. The third is work together to support health policy focused on prevention and, again, social determinants of health. So we think there are more opportunities for JPS to be involved in that type of work, and bringing its credibility to those forums where decisions are being made about those kinds of policies, we think could be efficacious. The next is working together to mobilize community partnerships to address particular health issues and or close health service gaps. So we talk a lot in our report about what some of the service gaps are, and I'll just pick dental for an example. Very limited dental access for very low-income people in this county. There are nonprofit hospitals have a requirement by their tax code to provide community benefit or to give back to the community financially. And one example would be for JPS and the health department working with these nonprofit organizations or hospitals to identify a couple of key priorities and say, we're going to pool our resources, and we're going to we're going to jumpstart a new dental clinic, or we're going to, support the FQHC in starting a new dental clinic, or whatever it might be. But to really focus those funds to leverage a greater good than they might in a disparate way. The next is expanding evidence-based community program to prevent disease and injury and manage chronic conditions. Some of that is going on right now, but to continue to do that, to train more people to facilitate those programs in communities that may not have been touched by those. For example, some Asian communities that may not be going to these types of opportunities. The next is, and final, is continue to consider existing Tarrant County Public Health and JPS facilities for potential service expansion sites or co-location and service collaboration where appropriate. There are actually 50 sites together. JPS, I don't know, I think you have 14 medical homes and 20 school-based health centers, and the health department has the remainder of those 50. And there might be some opportunities for, for the public health department to go to the JPS school-based health center and do prevention with kids, or to have a walk-in clinic at, for primary care at one of the public health locations. I'm not sure, but we plotted all of those to take a look at that and see if there might be some opportunities. And I think that's really all that I wanted to present today. Again, so that was, we talked about the community health needs assessment, we talked about voices in the community, and we talked about the potential partnership or strengthening of the partnership between the health department and JPS as the two county health entities. So, do you want to open up for some questions, or do you want to just move on to what you have next, JK, on your agenda?
Any questions for Lori? Lori, I didn't properly introduce you, and I'm sorry.
That's fine.
Because not everybody might not realize who HMA is and what you guys do. I think probably most people do, but just since we do have some new folks here, could you describe
Sure.
HMA and
Sure.
why HMA is here?
Yeah, so Health Management Associates, or HMA, it's a national research and consulting firm. We have offices all over the country, and we focus on publicly funded healthcare and public health. So we work pretty much solely with Medicaid, uninsured, underserved, Medicare, and really are expert in those areas. So we work a lot with public hospital systems and some nonprofit hospitals as well, but really safety net care is what we do and what we know. And so we responded to a request for proposals from the county saying, we want to do some long-term planning with JPS, and can you help us? And so we responded, and we're successful in getting this contract.
Okay. Thank you, Lori.
Yeah, sure.
Can you cite a couple of other counties, or not in Texas necessarily, that you've done?
Well, the closest one is Dallas County, actually. So we worked with Parkland and did a report for them in terms of their future. And this was several years ago. I think it was 2005, and had a blue ribbon committee, very similar to yours, and really helped shepherd them through that process of making some decisions and changes in their system. But we work with Los Angeles, Cook County in Chicago, San Francisco. We're all over the place, and then work with a lot of federally qualified health centers as well, and states and foundations, and so trying to address these issues of coverage from multiple angles.
Thank you.
Sure.
Thank you, Lori.
Yeah. Thank you.
So, yes, sir.
Madam Chairman. Lori, in going through your statistics and your projections of people, how many people would be under the federal poverty level, which then you kind of ratioed up, you took the percentages today and just projected them into the future, correct? And that was what
That's right.
if it was 20%
That's
today,
right.
you projected in the future
Yeah.
against the population.
Right, and that may change.
And is that typical, or would you try to overlay that with some type of economic forecast, jobs forecast, or anything else that could potentially change that? And the
Yeah.
other question, I have that question. The second question I have, and I'll let you answer both of those, is how static is that number? I mean, it's 20-something thousand now, I guess the federal poverty level. So how static is that number too, and who changes that number? What determines that number?
Okay, good questions. The first one, I just have to say, I think was a bit beyond the scope of what we were able to do in this contract. you know, we looked at a number of different universities, so Houston, the North Central Texas Council of Government. So a lot of people are doing this type of forecasting, and we pulled from there what we thought were reasonable estimates and, you know, not too conservative, not too, you know, out there. So to give you a good sense of where we think the population is going. You know, I think in terms of percent of FPL, you know, it was our best guess. We say, you know, maybe it's going to stay the same. We don't know what's going to happen in Fort Worth and Tarrant County in the next 20 years in terms of economics and where people are going to fall out. Your second question was
Yeah, the second
FPL.
question about the number and how it gets
Yeah, so
set.
that's the federal government, and how do they do that? Oh, shoot, I don't really
You
know.
don't know, okay.
I don't know.
It does get adjusted from time
I'm
to
sure
time,
that,
correct?
yes, it does. So I looked at the ones for 2017. They're practically identical to 2016. Very, very little
I'm
change.
assuming it has an upward trend.
Yeah.
I mean,
yeah,
it's
in terms
typically
of
going to
the-
have an
sure,
upward trend,
yeah.
and you've not counted for that in your calculations, though, correct? I mean, y'all didn't set an escalator, an annual increase. If you're projecting 20 years in the future, you didn't say that level is going to be higher in the future, correct?
No, but we did take the percentage of people in certain age brackets, and assuming the whole thing is going to move up, those percentages should be the same,
If you took.
or maybe the same.
Yeah, okay, yeah, hey, you know, you're talking, this is all statistics, so forth, but when it comes to projecting the same percentage, I mean, there's some other data out there that says when you have certain economic indicators or certain economic growth, I mean, there's economic projections for Tarrant County. And I'm just curious, it would seem
Yeah.
like that would be a trend that would be something
Right.
to pay attention to.
I might circle back to the Council of Governments. you
Yeah,
know.
because when I look at this data, one of the things that jumped out at me, and I'm a businessman,
Yeah.
is, wow, we just need more jobs for people. I mean, you know, JPS serves less people if people have better and more jobs.
That's true. That's true.
Right? You know, so one of the things that jumped out at me was that in the statistics, because I had never looked at these statistics. So the first thing I thought about was, okay, well, how good is our numbers in terms of projecting what the needs are when you start thinking of this public health?
Yeah.
Because that number that you projected, that's going to be those are going to be very important numbers.
Absolutely.
Okay.
Yeah.
Good questions, thank you. Somebody else, anybody else have any questions for Lori?
On the health status summary that you have on page 17,
Yeah.
have you worked with any other community that share the similar statistics, same characteristics?
I can't say
And-
overall, but I can say that we've certainly worked with many cities and many counties, and you know, that have disparate results based on neighborhood. You know, that the
What are the typical themes of solutions for these?
solutions. Well, that's a different.
I mean, you have themes of needs, right? These are
Yeah.
themes of needs. So
Yeah,
what are the
those
the
are
themes of a solution that you have experienced in other parts of the nation? Do you know?
Well, yes, I do know, but I think it'll take a long time because you have a lot of different healthcare issues there. So, you know, what do you do for diabetes? Well, you can actually prevent diabetes, and most people don't know that. But you know, you can prevent metabolic syndrome, which is the precursor to diabetes. So, you know, keeping trim, eating well, you know, those kinds of things. So prevention, and then early detection and early intervention. And making sure that people know how to manage their condition, making sure that the health care that's provided is accessible and evidence-based. I mean, there's just so many solutions for just one condition. So I think that you know, given where we are with this, it might be another conversation that I'd love to have.
I like to jump ahead. Sorry.
We had some discussion earlier about this adult diabetes prevalence heat map.
Yeah.
The conventional wisdom has always been that diabetes is a health disparity like many other health disparities, that it manifests itself more at a greater rate in communities of color. This map shows just the opposite. I've got some grave reservations about this map
well, we have the data, so I'm happy to share that with you.
You've got the data, I'd
I
like to
do,
see.
I do.
I'd like to see it.
Okay, I'm happy to share that with you.
Yeah,
But
Commissioner, the one thing that
I see you cite Esri as a source, and they are a very reliable source, but I'd like to see the data.
and one thing that I noticed on this map is somewhat difficult to see initially. This very bottom figure says the age-adjusted diabetes mortality rate per 100,000. And we're in the highest quintile. If you look, that's the
The shaded,
striped-
yeah.
That's the striped area. And what it shows is that the death rate for diabetes is greater in the southeastern part of Fort Worth.
right, so
Yeah.
this doesn't say anything about how well managed the diabetes is. It just says that there's a higher prevalence, maybe some, more people have it, but it could be better managed, and there's certainly people dying from it that are, in those areas that have lower prevalence. So it's a little complicated, but I'm 99.999% sure it's right. But I'm happy to share that with you. Okay.
You're right, I had missed that.
It was difficult to see.
Yeah, thanks for pointing that out.
I have a question, and it's on slide 27. And it deals, if you could just expand a little bit, the second bullet says the current, this is population growth implications. The current safety net hospital care workforce shortage will need to be addressed. Can you talk a little bit?
Yeah,
more
not
about
just
that, what
hospital,
it
but
is?
safety net healthcare workforce shortage, meaning that there aren't enough people who take care of low-income people in this community. So that's what I mean by shortage. So you have health professions shortage areas, you have medically underserved areas, you have physicians that are taking care, at JPS in the community that are taking care of way more people than an average doctor is because the demand is so great. So there's a real stress on the providers of this for this population.
That includes the number of physicians, new physicians that will take the place of those that are retiring, and also the increased population and the more demand on those. Is that including that?
Right, so our sense is that the number of providers that are coming into the system, if that continued at that rate and you had your population growth that was much more steep, then that workforce shortage would continue and probably worsen. So, yeah, an issue to be addressed.
Lori, is there any place, and I may have missed it on here, where when we talk about, and I'm starting to think again about these populations that are not close to JPS or they're transportation challenged to get here, is there anything in the study, and maybe this is just premature, there are a lot of providers that are not affiliated with John Peter Smith all through those areas. Mm-hmm. And it would be interesting, I think, to see if HMA has seen any approaches to utilizing the other providers in a county in some sort of a collaborative method. I know that the studies that y'all have done, and actually many have done, shows that in each one of those facilities there is a large group of population that uses those emergency rooms on a daily basis, both for primary care and acute care. And I'm not saying I have the answer for it, but it would be interesting to see if there's an approach of some sort that could use collaborative methods with those providers, as opposed to, well, we've got to assign so much money to John Peter Smith to go ahead and build another structure, or we have to go find the transportation for these people. I'm not saying that that's the right or wrong answer. I'm just wondering, have you run into
Sure.
any of those collaborative?
Yeah, there are lots of
And
things
they've
that
worked pretty well?
other counties have done. So, I mean, another neighbor, 3 hours away, is Austin, right? They have a healthcare district. They
Yes.
subsidize providers that serve the safety net because Medicaid doesn't cover many in this state, and the reimbursement rates are very low. So even if a provider is accepting Medicaid, you know, they can only take a limited number because they would go broke if they took, you know, more than, what, 8%, 6%, or something like that. So, so that's one, you know, thought. And other thoughts are, you know, kind of on another side of the spectrum is, you know, a loose collaboration of providers that volunteer their time in their own offices, and, you know, run by medical societies. You know, other, you know, counties in California do major subsidies, you know, for underserved population. I mean, so there are lots of different models for how to address that. You know, the first thing might be getting, I don't know, I think the political situation right now is not going to change where you are with Medicaid.
Right.
So,
Right.
but increasing the reimbursement rates would go a long way if that were possible. But so I think there are a lot of models out there that you could take a look at and see if they might fit here. But you're not alone in this. Other people try different things.
Yeah. Yeah.
Yes.
Well, I was just wondering, one of the things when I read this that kind of jumped out at me was you talked about collaboration between Tarrant County Health, Public Health, and John Peter Smith. Maybe GK, maybe you can enlighten us, or maybe somebody else in the room that can do it. So, what's the history of their collaboration, and is there a cultural difference? I guess I'm driving to why haven't they collaborated more? And is there some impediment to their collaborating? I mean, just seemed in my simple brain, if we're going to combat obesity, which I am trying to do every day, and you know, diabetes. Those seem to me to be things that if we do a big prevention program or something that brings it to the attention of the public in a forceful way, and especially if the Tarrant County Public Health and the hospital are collaborating, that seems to me to be something that would grab people's attention. So I'm just trying to figure out, is there something we should know about that collaboration, the history of it not happening, and is there an impediment for
If I could just
moving
interject
forward?
for a second, just to recognize that they are doing you know, some significant collaboration, even around diabetes, for example. So they have evidence-based you know, diabetes management programs and chronic disease management programs in the community that they both work on together. So there is some of that going on, but our recommendation was to take that a step further.
Okay. It just begged the question to me, why aren't they joining forces? Aren't they both county entities?
I think what you're going to find, Commissioner Brooks, you want me to start on this? I think what you're going to find is that when you look historically at the Public Health Department, at one time, and you have to look at the population of the county itself. At one time, there was a predominant health department, and it was the Fort Worth Tarrant County Health Department. And that was because you had a majority of the people that lived in the county resided in the city of Fort Worth. Now that has shifted, and you have a greater population that lives in the county than you do in the city of Fort Worth. So probably 10, 15 years ago, there was a split of those functions. And one of the reasons for the split was because the city was more concerned with items such as restaurant inspections, you know, vector control, those type of issues that a municipal public health department normally provides. The county was more interested in providing clinical services, preventative services, things such as that. So there was an initial split there. Peter Smith was not part of that discussion at that time because at that time Peter Smith had very few clinics. Their operations were mainly on the downtown campus, and they were focusing almost exclusively on treating those people that came to see them with an illness. And as Lori has said, since that time, and there's some of us that have been around that went through that experience, since that time, the county now has taken over a substantial amount of the public health functions for not only the city of Fort Worth, but for almost every other city in the county. I think the exception is Arlington probably, though we do a lot of collaborative efforts with the city of Arlington. And we are moving closer and closer to doing substantial programs that are collaborative programs with the hospital district. For example, the Ryan White aspect, the HIV/AIDS. We have some of our clinics. The hospital district has some of their clinics, but we collaborate substantially with that in providing federal funding to the hospital district in order to do some of those services. But even though there may be two separate clinics, they work hand in hand to ensure that whoever needs the services gets the services. It's not a matter of are we responsible for providing the services? Our charge is to make sure the services are provided. And I think you've seen, and I know Commissioner Brooks has been actively involved in that aspect of it, that the impact that we have been able to have on that particular community has been substantial because of those type of collaborative efforts. Obesity is another one, the anti-smoking issues or others. The one thing that public health runs that you might remember when Lori talked about the number of clinics and everything, the thing that the public health department runs are the Wic Clinics. And we have 18 Wic Clinics that throughout the county. And we try to collaborate with the district on services because our goal is to make sure those moms and babies are healthy, but then also to make sure we help them find a medical home. And in many cases, that's JPS. Is that a fair statement, Ann?
Yes, and I would say we share space with JPS in 2 of those 18 locations.
So there is more collaboration than
Collaboration
it looks like. Does that mean there should be more collaboration? Absolutely. You know, but I think we're moving toward that. But any help that we can get to collaborate and I will tell you the teams from both JPS and Public Health, they work very well together. It's not a competition. You know, it's just trying to figure out how we can leverage the resources that we have to have the greatest impact on the community.
And it's a small thing, but if you look at page 30, number 4 at the bottom of that page, that item should probably go under public health JPS collaboration because community health education traditionally has been a public health function.
Okay. And we actually, just for your information, both JPS, they hire community health workers, we hire community health workers, and we actually co-train with them because they need to have their continuing education. So there are a lot of things that go on in partnership, but to make things official as opposed to me just calling up somebody and saying, hey, let's do this, we probably lack that part.
Madam Chairman, did that answer your question?
Not really.
Well,
You asked about the history. That's the history.
Yeah, but the encouraging part of it, the response is that you're collaborating more and more.
Yes.
I mean, it just seems like it ought to be almost seamless.
Right, and right
but-
now, it's
You're
exactly
right.
what you said, which is it's relationship-based,
Yeah.
you know?
Relationship.
So
It's
to
not
have it at the highest level of the organizations and strategic planning and prioritization of what are we gonna work on together, those kinds of things, I think that's what needs to happen. And then all the rest will follow.
So you guys gonna do that?
I'm sorry.
No.
They grew up as two completely distinct disciplines.
Yes.
And over the years, public health has changed. It has evolved into more than restaurant inspections and disease control. And as they have expanded their view of what constitutes public health, for instance, violence is now considered a public health issue. There are many things that are now considered public health issues that were seen to be outside of the scope of public health 10, 15, 20 years ago. As the new public health model has expanded, then there has become closer and closer collaboration between hospitals as institutions. But by the same token, the roles of those organizations have changed as well. They used to be organizations that just sat there in their hospital buildings and waited for people to present for care. That model has changed now as well. So they're becoming closer and closer together in mission, and as they become closer in mission, they become closer in collaboration.
Well put.
I just wanted to make the point, just to raise it though, if we're going to, if ultimately both of their missions are to serve people and serve the Tarrant County residents, it just seemed to me whatever they could do to make that seamless ought to be the goal also.
Your
Make
point
sure that,
is exactly right. They should be seamless.
and I just hope that people don't get in their own silos and decide this is what we do, this is what we do.
Yeah.
But the people out there suffer because they
Yes.
don't get the
Yes.
service. That's
We're-
my point.
We're moving towards seamless.
Okay.
Good point.
Madam Chairman and
Yeah.
Commissioners, I mean, is it beyond this committee scope to think about a reorganization or recommend reorganization of those entities? I mean, you could reorganize or refold those entities so that they're focused on the things that we do. Healthcare delivery going all to JPS and the other items staying with the health department. I mean, is that beyond something the recommendations I would make?
From my opinion, if it is a part of the solution that we are seeking for the next 30 to 40 years, then I think it's worthy for discussion to the point of strategic collaboration or formal collaboration that you mentioned. I think that's the key in any solution that we deliver, because JPS alone cannot solve all the healthcare problems.
Yeah, that's right.
In a growing county like Tarrant County, behavioral health is a huge issue. You can build a lot of capacity, and I can guarantee you by the time the construction is complete, the capacity will be exceeded.
No, exactly.
Okay? So, going along with the point that you were saying, I believe somehow, not only in public health and JPS, but in with MHMR and other behavioral health organizations, and somehow among the medical schools, the hospitals, the private and non-profit hospitals, we have to come up with somehow a strategic, collaborative model to really advance healthcare objectives systematically, okay, not just based on relationship and so forth. Really have to be able to systematically measure the effectiveness of the programs.
And particularly since Randy mentioned in the next 6 years, Lanny? I'm sorry.
Lori.
Lord, I'm sorry. Randy's age population is going to grow exponentially.
We are, we definitely are.
Because that makes it, Commissioner, even more important that we think about these collaborations now. Because in 6 years, if 40% of the 65 and older are going to increase it,
4 years, I think,
yeah, it's just, it's going to be,
like tomorrow.
Right, 40%
Yeah, it is.
increase.
Yes.
40%
Really
4
is.
years.
40%.
It really is.
2015 to
That's
2017.
incredibly.
2021, sorry.
It's 2021.
Yeah, right,
It's 4 years.
yeah.
Okay, anything else for Lori? Thank you, Lori.
Okay, sure, thank you.
So, GK, is Patrick going
Yes.
to make a presentation
Yeah,
today?
A very short
Oh, there he
presentation.
is, over there, I'm sorry, I didn't see you there.
As
Yeah.
Patrick comes to the front, remember, Cumming is the entity that we contracted with to look at facilities. And Cumming is a national firm, and this is their area of expertise also.
Okay.
And so at some point, there will be a merging of what Cummings will discover about our facilities and what Lori,
Absolutely. Absolutely.
Implications of our report on their work.
Can I ask one question before you begin?
Absolutely.
Do we have anyone looking at the current resources at JPS? I'm talking about strategic partnerships, relationships that we have, partnerships and so forth, beyond just facilities. I'm talking about facility is part of the physical infrastructure, right? What about the technological as well as the human side? Do we have anyone looking at that?
HMA has been looking at that area,
Okay.
and as we go along and receive some of those reports, we want to make sure that if we need to cover more in that area, then we can look for other resources also.
Okay. So,
But yes, we have a whole finance chapter.
okay, that's gonna be addressed at a later time. Okay, thank you.
Thanks, GK. Thanks, everyone. We're excited to be a part of this project, and as much as I'd like to come before you and take all the credit, and give all the credit to Cumming, I have to share with you, we have 6 specialty sub-consultants that we've had on this project. I'm gonna talk a little bit about what we're gonna do going forward. It's listed as a status update. We're just getting started, so the status is, we're just getting started. We're digging into a lot of the documents, trying to get a real understanding of exactly where everything stands. But we have really 2 different pieces that we're looking at. One, the larger piece, is looking at the HMA document and the Blue Cottage report that was done a couple of years ago. And in as much as those have bricks and mortar or facility solutions, look at how we bring those to bear and what are options for that. You know, the other report was really focused primarily on all new buildings. And that's not to say there won't be new buildings in this report at the ultimate end of what we're doing, but we're going to look at what are some options between all new buildings, all new renovation, and how does that play? And what's the sweet spot in there from a financial perspective? Another piece of what we're doing, and it goes to what some of Lori was talking about, the care in the community, is an ambulatory network study. One of our partners is Percival Health, and Sam Sears is here with us today. I was going to ask him, warned him about not putting him on the spot, but I was going to ask him just to take a moment to talk a little bit about the ambulatory network plan that we'll be putting together.
Sure. Want me to do that now?
Yeah, please.
Sure. Yeah, that's fine. I talk loud too, so. My component of this, that at least I'll be focusing on, or my group, Percival Health Advisors, will be focusing on, is as Patrick mentioned, we're calling it the ambulatory network plan, or ambulatory deployment strategy. So if you think about your current footprint of ambulatory assets, right now that is primarily, and Lori mentioned this, the school districts, or you're embedded in some of the school clinics. There's quite a few of those. There's some of the free clinics. There's the medical home model, of which you have 14 of. Frankly, that'll probably be our main focus, because I think that's going to be your greatest opportunity for growth out there. And you do have some ambulatory surgery. You do have some specialty clinics as well. You know, Lori mentioned we will be working closely with the HMA team, around sort of translating their future needs and capacity concerns into clinical solutions out in the community. So if you think about all that's going to be invested in the campus, before you make that investment, you want to make sure you're fully thinking through what kind of care can be delivered in the community. So I've already started on that. In fact, I've spent the last 2 days actually driving around Tarrant County and looking at especially the medical homes that you have, outside of the downtown area. So I want to really focus on creating more access points for the community out there. And so we'll determine what exactly that's going to look like, but also, where should you be, how big should they be, what kind of services should you offer there. And primarily the focus will be on physician services and ancillary healthcare services, things like imaging or PT or whatever might go in those sites. So that is primarily what I'm tasked with and what I'll be working on over the next couple of months.
Thank you.
Thanks, Sam. So the other piece of that I was talking about was it is generally focused on the main campus and focused on following the work that Blue Cottage had done and how the HMA report is going to impact that. In addition to looking at the strategic vision that they're going to outline in the existing documentation, we're going to do some studies of those existing facilities on campus and look at those based on industry standards for healthcare delivery. What are the opportunities with those buildings? Identify, are there buildings that have really gone past their useful life and maybe in need of decommissioning, or are there buildings that are able to be renovated in order to support some of these new or expanded services? And we'll start to overlay all of that, and the end result of that work product will be what's going to have our second opinion study of the cost and the options that you're going to be able to have.
Okay. Any questions for Patrick? Thank you, sir.
Thank you.
As you can see, Cumming is just beginning their work. They've been on board now for about 4 weeks. And so as we go forward, you're going to be hearing more and more from Cumming and also with HMA.
Okay, so is Scott going to tell us a little bit about the tours?
Right.
Right, is this good?
Yes.
Can you hear me?
Yeah.
Terrific. Okay, terrific. It's my understanding we do have the dates for the tours confirmed. That's the 24th and the 28th of March, and each one of you should have signed up for one of those 2 dates. Details and logistics will be out shortly, but I do want to confirm that we encourage you to meet at a central location that we'll provide on the date of the tour, and we'll provide transportation so that we all stay together and we can hear the same things and see the same things. And so we'll have transportation available. The tour will include JPS, the main campus, Southeast Medical Home, Stop 6, and the FQHC. And of course, we'll have travel time between those stops, but at least for the initial tour, those are some of the sites that you'll see. Certainly, we want that to conform with your expectations and what you want to see. So if you have any questions or any comments about the tour, please let us know.
Scott, me personally, I think probably the most interesting and fun part of this
It's
will
going to
be
be
the
fun.
tour.
Yes.
But I like to relate it to what HMA has done. So we're not, again, in a vacuum, just looking at stuff and have no relationship to what it is we're seeing. So I don't know, maybe the doctors have a better sense of what we should be looking for when we go to tour. But I think if we can somehow tie it and make it relationship, whatever.
Yeah.
So that we can,
Sure.
so we what we see, you can reference back to what we've read. And
Sure. And I think what might be very important is for each of those sites or each of those locations provide you with some information, really, patients by the number, right?
Yeah.
Exactly what's treated, who's treated, why are they treated there? What are the demographics of the patients, and what type of things do we see at those clinics? And that might add some context to those sites as well.
Do you think it's possible, having just done this in Maricopa County, it wasn't just the public hospital sites, but it was all the other system sites that were very protective of their domain, but you very quickly got this heat map of where there was coverage. And I'm just asking, I know that would be complex, but it would be fascinating to see where a JPS site is, but then to see where, pick your poison, a THR site
Sure.
or a Baylor site.
Sure.
Because it'll give us a sense as to how many blocks away, how many miles away, because again, going back to the transportation issue.
Right. So you're saying not as part of the tour, but actually some data on that?
Right, I mean,
Sure.
it probably would make the tour a little
Too
too
long,
granular,
yeah.
but it might be just nice to put it, as we go to a site, what the perspective is for the surrounding 3-5 mile radius for other carriers, other entities that exist.
I think that's a great idea. Glad to do that.
I actually have maps of exactly what you're talking about. So you want to
Lori,
bring
I'm
them
gonna
on your tour.
Yes.
So there are, I think, three maps.
Lori, let me ask you to grab a mic, okay, so we can capture what you're about to
You
say.
can go right there.
So they're a combination of, there are three maps. One is, you know what, they're in packets.
Right.
Yeah, okay. So, yeah, so there's a primary care map, which has the whole county with all of the safety net primary care providers. With, you know, in the legend, you can see which they are. And then there's an attachment that actually has the name of the organization, you know, like Elizabeth, your organization is there with your sites, and it has a different color than the JPS sites versus other system sites and the addresses. So there's another map that is behavioral health, and there's one that has dental sites on it as well, and another one for specialty. So I think the one you're looking at now is primary care.
Yeah, this doesn't
This is
have,
the specialty.
Well, these are GPSs.
yeah, this doesn't have.
Okay, so you know, these are not all the same thing, so we just need to make.
Oh, I see.
Yeah, sorry, I just handed her the packet. So there are three
I think we
different
understand what your question
sets of
is, and I
maps.
think we can put those maps together.
Thank you.
Terrific idea. Any other questions or comments about the tour?
Yeah,
Otherwise,
it looks like we got different things.
Yeah.
Right.
We have dental
Yeah.
and specialty.
I'll
Yeah.
give it to you after the meeting.
Okay.
Give everyone the right.
Yeah.
Right.
Any other questions for Scott? Scott, we appreciate you and your staff putting that together. We know that's gonna be a kind of a complicated logistical thing for you, but, as we invade the different sites, but I know you guys will do a great job putting it together.
Look forward to it.
So in that parking at John Peterson, in that parking lot that we can just roll up and leave our cars and then,
We're gonna be at a central location.
that central, could that be?
We're gonna be at a central location.
Probably the Health Center for Women, which is right there on Main Street in Rosedale, basically, which has ample free parking, will provide a great opportunity for us to meet at one place. Once again, get in common transportation and then go on the tour. Okay.
Okay, GK, were you gonna talk about April meetings?
Do we need to wear tennis shoes?
Dress comfortably and wear
Don't
walking
wear your
shoes.
6-inch heels. There's a collaboration that's important to this process that has not been talked about. And that's the relationship between John Peter Smith and Cook Children's. And there's an MOU, I believe, between JPS and Cook Children's in which the understanding is expressed that Cook will take care of the children and adolescents, and JPS will take care of the adult population. Did I state that correctly?
I think to a certain extent. Scott, why don't you see if you can answer that question? I know that Peter Smith handles a lot of neonatal aspects.
Yes, that's correct. I mean, we do have a great relationship with Cook Children's. Without speaking to a specific MOU, I can tell you that we deliver approximately between 4,000 and 5,000 babies a year at JPS. And if there is an outcome that we wouldn't expect or something is wrong with that baby, we certainly will stabilize them at JPS, but for the most acute care, we will transfer them to Cook Children's. From an outpatient perspective, although we do have a pediatrics clinic and primary clinics, we don't have a large footprint of pediatric care. We We rely on Cook Children's to provide some of that, as well as a lot of pediatric specialty. We have very little, if any, pediatric specialty services, and once again, refer those to Cook Children's. We have a great relationship and good collaboration with them.
Scott, following along that path, so John Petersburg has nurses in a lot of the different schools. When they run across a situation that needs follow-up, is that usually passed on to cooks then?
I'm sorry, I lost you with the education component. In
Okay,
Cook,
I'm sorry. So you have the school nurses, the
Sure.
school nurse program, and when they come across a situation that needs follow-up, do they normally, I'm just asking from a process
Okay,
standpoint,
sure,
is it
okay.
normally sent to cooks then?
Yeah, depending on that patient and the diagnosis or treatment that would be done, we would provide referral to the appropriate site of care, which in a lot of cases would be Cook Children's.
Okay, yeah, thank you. Other questions while we got Scott on the mic there? Okay. GK, you want to talk
Yeah,
about
we'll talk a little bit about the topics for April. HMA is finishing up their reports, and what we would like to do in April is to provide you all with the final drafts of those reports and have a final presentation by HMA that will include that is above and beyond what you saw today, and kind of finalize their presentations to the committee as to their full report. Is that a good way of saying that?
In April and probably into May as well.
Yeah, that will, we think that there's a lot of material here, okay? Yeah, okay, and what you received today was very substantial, and there's still a lot of material that HMA has developed and putting into a final draft form. We'd like to get that to you all as quickly as possible, so we anticipate that the April meeting and part of the May meeting one of the May meetings will also include that material. You're then going to be beginning to bring forward some of their reports. And so I believe that with the tours, what you're hearing from HMA and what you're hearing from Cumming, that it'll start to blend together. And that was the goal for us, to have these outside reports blend so that this committee could then come up with a bigger picture of the issue that we're studying and then begin to formulate some recommendations. So that's what's going to happen in April and May. We also have, by the way, there was a request for a financial report. We're also going to have John Peter Smith, along with HMA, do a presentation to you all on the hospital district's finances. That's going to be led mainly by JPS, and so that will be following that, probably that second meeting in May.
And then we're gonna get into the quandary after April, May, then it's vacation time and people are gonna be scattering to the winds. Hopefully not.
We don't take vacations at the county.
Well, I didn't think so, JK. But that's important, our dates, and I think one of the things that we wanted to come to kind of a consensus on was, when are we gonna meet, and how often are we gonna meet? So that everybody gets a chance to hear everything so you can make those decisions. Because if we don't, then we'll have Randy left out, and he can't make the meeting, darn. So, we thought, we kind of talked about, kicked around, maybe trying to meet every 3 weeks. Often enough so that we can keep our fires burning and keep the information going and get to the end goal here to make the recommendations. But not so often that we get sick of looking at each other.
No, that would never happen.
Never happen.
No,
Okay.
no.
But we wanted to make sure that we met often enough to move this ball down the down the field, to the goal line. So, can you just tell us if 3 weeks is enough, if you wanna meet every week? Okay,
I'm gonna
we
bet they
eliminate
don't
that
want
one,
the
yeah,
every week.
okay. So 3 weeks, is that
Does that cause
pretty much-
heartburn for anybody?
Whatever it ends up being, can we get it on the schedule
Yes.
now for the next 4 or 5 months?
I believe GK's got it.
He
Right.
has, and
If we stick with this Tuesday afternoon and we go to every third week, right? That's what you're
That's
saying.
correct. Our next full meeting here after the tours then would be April 18th. And we will send you out a schedule that will go through at least July.
okay. Because I think the earlier we know the dates, the better people can plan around it, don't you think?
We can push this out
Do
to
you-
September. We'll get you through the
Okay.
September dates, okay?
Yeah.
Because that's going to give
Yes.
Cumming and HMA enough time between to give us a very, I mean, is that enough time, 1 week short, to provide information for us?
We looked at that and we believe that we will be able to do that.
Okay, good. Thanks, Pat.
Okay.
In,
Now,
in
this-
addition to a calendar of meetings, Madam Chair, is it possible for us to identify a list of topics for discussion in alignment with those meeting dates so that we will be able to have a logical sequence of almost like a meeting plan
Yeah.
so that we will ultimately arrive at
That's the goal.
measurable
Yeah.
objectives instead of we have a lot of moving parts. You see them?
I understand what you're saying. In fact, what we'll do when we send the meeting dates out, we will give you the suggested topics that'll be covered on each one of
But
those.
what I'm saying, we think of those topics ahead and then try to move in that, into that logical sequence.
Commissioner, we've already had those discussions where there would be a logical progression on topics so that it'll lead everyone through a process that hopefully will add to rather than just, shotgun things out.
I think it probably looks, Tisha and I had a little bit of a sidebar discussion on this. We're kind of freewheeling right now because there's so much information, but this will begin to squeeze down as we begin to focus on areas that we either say we cannot impact or areas that we can impact, and then make decisions accordingly on that, so. I hope that helps.
Well, GTA has been very good, and the staff of talking to us early on to make sure that our meetings are fruitful, that you're not coming in trying to put things together. We're trying to make sure it is useful and meaty, moving us down the road to the goal. So. Now, does the Tuesdays work?
Yes.
Once you start it, it's hard to get off of it. So, okay, Tuesdays at 2:30 is pretty much where we're gonna be? That works?
Okay. Sounds good, Madam Chair.
When is our next meeting?
Okay.
After the tours, our next meeting is April 18th.
She took mine away.
April 18th, so there won't be one on the 28th.
There's a tour on the 28th of March, so 24th and 28th.
24th, either or.
Yes.
And then April 18th.
Yes.
Thank you.
Okay,
We're fine.
all right. Madam Chair, we ready to adjourn?
Do you
I move we adjourn.
Second.
It's been properly moved and seconded.
Thank you,
Did
everybody.
everyone hand me back their maps that they received, the original ones? I know
So
I
we're
gave you.
supposed to have 3
Correct.
texts.
So if you have your original one, you'll hand that to Jay.
We are or not? Are not this number? Yeah. That would be my third.
Have we validated their